faculty of the McLean Center for Ethics there, which is where I got to meet Farr, who has been a wonderful colleague and a very good friend to me personally. Farr is a first-rate human being, and he reminds me, as a believing Christian physician, of the joyfulness that's supposed to come with our faith. I am always struck when I'm in the presence of Farr of kind of a very deep and real happiness that occupies his life. So it's a real pleasure to introduce him and to have him here today. And thank you, Farr.
Thank you, John. I don't have any slides either. I hope you will forgive me. I want to say, for those of you who are interested in the content of this talk and would like to, if there's one of you in here, perhaps they wanted to think about it more, it hews pretty closely to comments I made to the President's Council on Bioethics on September 11 of last year. You can find those on the website if that interests you. And if you're interested in thinking hard about this issue of conscience, its place in medicine, and how we ought to think about conscientious refusals of certain clinical interventions, I would commend to you a special issue of Theoretical Medicine and Bioethics. Theoretical Medicine and Bioethics. It was published the fall of 2008 on this topic. And I had the privilege of editing the papers for that. And there's some really wonderful pieces there that show a range of different opinions. But I think if you were to read those papers, you really would come away with a strong sense of what the core issues are. And there's a paper in there by our own John Hart, interestingly, something on the title of Conscience Resources for Rapprochement from the Perceived Source of the Problem. And he talks about some of the Catholic tradition.
It's a catchy title, isn't it?
It's a catchy title. There's also a terrific essay by Dan Sulmazy, a Franciscan friar, physician, and new colleague of mine, whose work I would commend to you in its entirety. But there's a great essay there about what the conscience is and how we ought to think about it. Now, talking about conscience in this setting, I think, is appropriate for many reasons. One of which is that Catholic healthcare seems to be always in the thick of this. And at the front of this topic, it is really Catholic healthcare is one of the foremost contexts in which questions are raised about whether it is justifiable to refuse to provide legal medical interventions which patients seek, and if so, for what reason. It's also the case that as we think about healthcare reform, the U.S. Council of Catholic Bishops is, even yesterday, has been making known in a kind of public way their concern that current protections of clinicians' freedom to conscientiously refuse to participate in things that they find objectionable is not eroded, and in fact seem to be asking for a greater strengthening explicitly of those of former laws that protect clinicians' freedom to opt out of those sorts of practices. Now, I'm not going to get into all that policy. What I'm going to attempt to do is attempt to help us think rightly about the conscience, what it is, how it fits into the practice of medicine, and from that think together about how we should approach the phenomenon, which is very real, of patients requesting from their clinicians, or in some cases clinicians requesting of other clinicians the provision of some intervention which the clinician cannot provide or participate in good conscience. All right, that happens is a fact for many people in healthcare, and so the question is, well, what do we make of that? I'm going to argue that there is no obvious professional obligation to provide the sorts of medical interventions that have stirred of late this controversy about conscientious refusals in medicine. And I'm going to suggest that conscientious practice, particularly if it is accompanied by candor and respect, is perhaps ironically the best hope we have for achieving ethical clinical care, especially, not as well, but especially when clinicians cannot agree on what good practice requires. And in my comments, I'll focus on clinicians because physicians, because I am a physician and I know the world of physicians best, but I think that most of what I say also applies to other healthcare professionals. And perhaps we can talk about that in the question and answer time. To begin, physicians commonly refuse to provide clinical interventions that patients request, even when those interventions are legal and permitted by the medical profession. That is to say, to borrow the unfortunate and misleading rhetoric that is often used, it is to say that we physicians often impose our values on patients. Now, these refusals are neither new nor are they peripheral to clinical practice. In taking the Hippocratic Oath, physicians have for centuries sworn to categorically refuse to provide either abortifacients or any drug or information that will be used to help kill patients. In the words of the oath, no matter how implored, I refuse. Sometimes physicians refuse interventions that are the subject of widespread public dispute, such as abortion or emergency contraception, but more often their refusals occasion little controversy. For example, surgeons refuse to operate when they believe a surgery is unlikely to be successful, whether or not all of their colleagues agree. Physicians refuse requests for antibiotics or other remedies, even if the patient's symptoms may satisfy some threshold criteria for using these medications, if in the physician's judgment they're not warranted. Physicians may refuse requested interventions because of concerns about safety or efficacy, or they may refuse because of concerns that are less tangible, if no less real. For example, some Catholic physicians refuse to provide contraceptive medications because the Catholic Church teaches that such medications illicitly separate the procreative and unitive aspects of human sexuality. More commonly, it seems to me, physicians' intangible concerns are not explicitly religious. Some pediatricians refuse to provide growth hormone injections to boys who are particularly short because they're concerned about crossing a line between treatment and enhancement. Internists and family physicians sometimes refuse intensive workups and treatment regimens for what they believe are psychosomatic syndromes because they are concerned about being good stewards of their colleagues' time and other medical resources. Physicians who will abort fetuses with lethal congenital anomalies may refuse to abort those with Down syndrome or cleft palate out of concern about societal attitudes toward those with disability. To say a refusal is conscientious is simply to say that it is based on a physician's best judgment about what he or she ought to do in a given case. Conscientious refusals need not be based on religious reasons. They need not be emotional or dramatic or obscure. They are merely refusals based on what physicians believe are good reasons. And in a morally pluralistic society such as ours, such reasons will not be persuasive to all. But they should be intelligible and at least plausible. To say that conscientious refusals are central to the practice of medicine is not to say that every conscientious refusal is justified. A conscience that is malformed or misinformed will err. For example, a conscientious physician may fail in her ethical obligation to relieve a patient's debilitating pain because she has not been trained to value relieving pain. Now, this would be an example of a malformed conscience. Alternatively, she may fail because she incorrectly, no fault in the sense of blame or of blameworthiness of her own, but she just incorrectly interprets the patient's behavior as drug-seeking and malingering. And this would be an example of a misinformed conscience. The conscience as a human faculty is both limited and fallible. Yet, however fallible, conscientious refusals are a necessary consequence of physicians exercising discernment, or what we've always thought of as, or called by the name of clinical judgment. So with respect to the present controversies, and the present controversies are about things like palliative sedation to unconsciousness, as it's been called. Obviously, postcoital contraception, the range of contraceptives, and other such activities. It cannot be that conscientious refusals per se are ethically problematic. What we're after are criteria by which to distinguish those refusals that are consistent with physicians' professional obligations from refusals that contradict those obligations. To find such criteria, we have to figure out what, in fact, physicians are obligated to do. It has been self-evident to people from virtually every culture and moral tradition throughout the centuries that physicians are obligated to care for the sick so as to preserve and restore their health, insofar as is reasonably possible, using reasonable means at reasonable cost. The Hippocratic Oath says, "Into whatever houses I enter, I will go into them for the benefit of the sick." This, by the way, was part of my question to Father O'Rourke about the well-being, and I'll take a minute to talk about this, turns on, I think, the importance of specifying what we mean by well-being. And I'll get into that a bit later, but I think Father O'Rourke and I would probably agree about this. We'll see. But medicine is about more than health, it seems to me, in the sense that we are not about health as merely an end in itself, but about health, the restoration of health, so that a person can return to living a worthy, full, flourishing life, a good, faithful life, insofar as is possible. And health here, by health here, I don't mean a kind of a norm that can only be measured, or even most properly measured, with numbers on a lab test or with vital signs. Leon Cass, a colleague at the University of Chicago, with which some of you may be aware, I think defined this quite helpfully, and it seems to me rightly, when he says that health is an objective norm that is the well-working of the organism as a whole.